Zoll technology will guide you to meet the 2015 CPR guidelines. High-quality resuscitation on the move is achievable, and high-perfusion CPR is within reach. When it comes to helping you deliver high-quality CPR, no one offers you more than Zoll.
Good morning, ladies and gentlemen. Thank you for that kind introduction. I'm a cardiologist, and I'm a EP or electrophysiologist, which means I'm a heart rhythm cardiologist. I have great respect of my colleagues at the Department of Emergency Medicine because they handle so much varied scenario. They are very capable of returning someone almost dead with signs of spontaneous circulation. When I receive these patients, I handle them like a baby because they are very precious. But today I'm not going to talk about atrial fibrillation, which is one of my pet topics. Being a heart rhythm doctor, this is something that I deal with on a regular basis. We know that atrial fib is going to be a common occurrence in your department, in any internal medicine department, in cardiology, in emergency department. Up to 10% of encounters may involve atrial fibrillation in some reported series. Have no doubt this will increase as the mean age of the Singaporean population goes up to the low 80s. The chance of getting AFib in the 80s is 1 in 10 versus 1 in 1,000 for anyone age 50 and below in this audience. And we do know that the mortality and morbidity with atrial fibrillation is increased. They have, I'll show you in a slide as to some of the sequelae of atrial fibrillation. This is a typical ECG of a person with atrial fibrillation. As you could see, there are really irregular R to R. R to R refers to the QRS, R to R waves. You find that these are not regular. Number two, if you look at the baseline, there are no P waves. In fact, they are what we call fibrillatory waves or even flutter waves over here. If you are able to measure, if you are able to put a caliper between two P waves, the P to P interval is less than 200 milliseconds, that would be one big square at a ECG strip running at 25 millimeters per second. Atrial fib can be classified into the various forms of classification, but the easiest will be a temporal form. Is it a paroxysmal type, which means it comes and goes and usually terminates to sinus rhythm within 48 hours? We call that paroxysmal atrial fibrillation. Or does it last longer than that, more than 7 days, or you need some form of intervention? Usually some drug intervention. You need to give them some form of antiarrhythmic drugs to restore normal rhythm, or electrical cardioversion to restore normal rhythm. In this group, we call them persistent atrial fibrillation. If they have it for more than a year, but the physician intends to do what we call rhythm control, as in he still tries and believes that he could restore normal rhythm at one point or another, we call them long-standing persistent atrial fibrillation. It denotes the intention to restore normal rhythm. If, for any reason, the physician or the patient gives up and the patient remains in atrial fibrillation, we call it permanent, or we resign to the fact that he'll be in atrial fibrillation. Now, this is the trouble with atrial fibrillation. Death rate is doubled. We do know that patients with atrial fibrillation has an increased risk of strokes, a 5 times increased risk of stroke compared to one without atrial fibrillation. And the outcome for strokes sustained by that patient with atrial fib is worse. You are more than aware than I about hospitalization or unplanned and unscheduled clinic visits and hospitalization in this group of patients with atrial fibrillation. The quality of life and exercise capacity drops dramatically. And in some patients, they may have what we call tachycardia-mediated cardiomyopathy, where they remain in atrial fib when the ventricular response is too fast for too long. That weakens the left ventricular ejection fraction or heart function. The goals of AFib management are really threefold, and that could be instituted anywhere in the ER, in the clinic, in the primary care, internal med physician, in the cardiologist's office. Firstly, we risk stratify them for risk of stroke and start a relevant anti-thrombotic therapy. We decide whether they always receive some form of rate control measures. For example, you give them beta blockers to slow down the ventricular response. If they're not suitable for beta blockers, you start them on the calcium channel blockers like verapamil, like thythm. All right. in addition to rate control measures, we decide whether they are suitable candidates who might benefit from aggressive rhythm control. And that usually comes in the form of antiarrhythmic drugs, as well as electrical cardiotherapy or catheter ablation. It is also a good time to screen and treat underlying or associated diseases. And of course, you may want to refer to a cardiologist for a complete workup for this patient. This is a risk score that we use to risk stratify anyone with atrial fibrillation. In the past, we used a CHETS, but we realized that's too rudimentary. With the advent of new drugs to reduce the risk of stroke, we moved on to a CHETS-VAS. We look at patients whether if they had a past history of heart failure or evidence of LV dysfunction, they get 1 point. The presence of hypertension give them a 1 point on the score. Age 75 and above, they get 2 points. Presence of diabetes, 1. If they had previous stroke, TIE, thromboembolic phenomenon, 2 points. Presence of vascular disease, for example, if they had peripheral arterial disease, they have atherosclerosis of the carotid artery, or they had an MI or coronary artery disease on the CT scan, they get 1 point. If they are of a younger population, for example, 65, they get 1 point instead of 2 for age. If they belong to the female gender, they get 1 point. Give you a maximum score of 9. And this is the risk stroke associated with the various CHETS-VAS score. Let me just help you focus to CHETS-VAS 1 or 2. If anyone with a CHETS-VAS score of 1, the adjusted stroke rate is about 1.3% per year. That's not very high, but not insignificant. And this is the CHETS-VAS that we look at to implement antithrombotic therapy, and I mean anticoagulation in this group. Traditionally, warfarin gives a good person a risk of 0.8% risk of intracranial hemorrhage per year. So truly, with a stroke rate of 1.3%, it is amenable to start anticoagulation for the benefits outweighs the risk of therapy. With the advent of new drugs, the new drugs such as the new oral anticoagulants, which the next speaker will talk about, like apixaban, the bigatran, rivaroxaban, the intracranial hemorrhage rate is half of that of warfarin, of 0.4% per year. And hence, we strongly advocate that anyone with a CHETS-VAS score of 1, apart from being a woman, which means if you're a lady with atrial fib, being a female gender, if their score is 1 due to the fact that they were ladies, we discount that. We would recommend starting anticoagulation. And this is some of the guidelines that are out there. ESC 2012, the Asia Pacific Heart Rhythm Society in 2013. Anyone with a CHETS-VAS 1, we recommend anticoagulation, which is warfarin or NOACs. Now, the choice of rate control medication depends on their lifestyle. If they have an inactive lifestyle, perhaps the digoxin might be useful. If they have an active lifestyle with associated diseases, we look at whether they have hypertension, because if they do have a beta blocker, a calcium channel blocker is useful because it controls the blood pressure as well as reduces the ventricular response to atrial fibrillation. Presence of heart failure, beta blockers is shown to increase or decrease mortality, and a good drug to use. If they have COPD, then of course we have to avoid beta blockers. If we need to use, we use the beta-1 selective beta blockers. Now, who benefits from rhythm control? The young age. I would define anyone less than 60 years old as young, because 65 and above, we have clear guidelines on how we treat atrial fibrillation, especially in antithrombotic therapy. But anyone younger than that, the recommendation becomes a bit more murky and gray. Young age, because the complications of atrial fibrillation is related to the exposure length of atrial fibrillation. So we can't treat, and we should not treat a 45-year-old with atrial fibrillation as we would treat a 70-year-old with atrial fibrillation. If they are symptomatic, despite rhythm or rate, I think nothing beats rhythm control, or nothing beats restoring normal rhythm when they are hugely symptomatic. If they have evidence of tachycardia-mediated cardiomyopathy, which is to say that the cardiologists have seen this patient, he has a poor EF, they have done all they could to screen and test, and they have no obvious heart disease apart from what we call non or dilated cardiomyopathy. If we are able to restore normal rhythm and the EF improves, we know that atrial fibrillation was a causative agent in this case. The presence of LV dysfunction or presence of heart failure, a normal person with a normal EF may tolerate atrial fibrillation due to its the poor atrial contribution to cardiac output. They withstand that cardiac inefficiency. But in a person with poor EF or previous episodes of heart failure, they really benefit from the atrial contribution to their cardiac output. And I think they would really benefit from aggressive rhythm control strategy. For the same measure, anyone with hypertrophic cardiomyopathy, aortic stenosis, the atrial kick or contribution to cardiac output is important. And they are a group whom we should maintain rhythm control. Or previous strokes or TIA, the recent literature suggests that for every CHEST score category, the type of atrial fib predicts the risk of recurrent strokes. Those in permanent atrial fib does poorly compared to those in paroxysmal atrial fibrillation. But of course, the principles to maintain antiarrhythmic, it's really not easy, or rather, antiarrhythmic drugs do have side effects. As with all drugs, they are a double-edged sword. Most of the time, it helps the situation. In some situation, it worsens it. And in the meta-analysis, up to 25% of patients on antiarrhythmic stops it for various causes, in the inability to tolerate side effects and major adverse events. All right, these are some of the principles. We are motivated by attempts to reduce AF-related symptoms. The effect is at most modest. Amiodarone, the favorite drug of cardiologists and ER physicians, maintains sinus rhythm up to 50% to 60% in patients with paroxysmal atrial fibrillation. We do know that amiodarone has a whole host of side effects, more so if they take it for more than 2 years. It stays in the whole system. It's a good embalming agent. It stays in the eyes, the thyroid, in the lungs, in the liver, in the gut, in your skin, on your nerves. All right. So if antiarrhythmic drugs fails, we may have to use other agents, and safety rather than efficacy is a main consideration, and it guides our choice of antiarrhythmic agent. This is some of the success rate with pharmacotherapy, up to 80% if it's a short onset of atrial fibrillation. Half of that if the onset is more than 48 hours. Electrical cardioversion is very effective, more than 90%, but only 1 in 4 remains in normal rhythm at the end of 1 year. Of course, there's catheter ablation in suitable patients with atrial fibrillation. This is a summary slide on the choice of antiarrhythmic drug, which is guided or influenced by underlying pathology. If they have no or minimal heart disease, do think of flecainide, a type 1C agent, or sotalol, before you consider amiodarone. But if they have some form of underlying heart disease, you could see that wherever it goes down to amiodarone. Sotalol in some cases, amiodarone in the rest. Truly, in patients with underlying structural heart disease, our choice of antiarrhythmic drugs is truly limited. Now, this is the ACLS provider manual in Singapore on how we could treat patients with atrial fibrillation at the ER. So if I point you down to this atrial fib, if they are stable, if they are unstable, with signs of hypotension, altered mental state, pulmonary edema, you proceed to cardioversion. If they are stable, if you think of a rhythm control, it goes down to IV amiodarone. All right, this is a summary of what was recommended in Singapore. Now, I've looked through the literature, and the Canadians have come up with a fairly advanced and forward and progressive algorithm for treating atrial fibrillation in the emergency room. Atul Verma is a good friend of mine. He's an electrophysiologist too. Both of us trained at the Cleveland Clinic, and he wrote a section on AFib in the emergency room. Similar concept, but if they are stable, is there an immediate risk of stroke? If the risk of stroke is low, defined as recent onset, he's already on therapeutic oral anticoagulation, do think of pharmaco or electrical cardioversion, and send the patients back for an early referral to the cardiologist. If they are high risk, these are what we could do. You could do rate control. If they're stable, send them to the cardiologist for an early appointment. If they're unstable, we probably have to admit them for a TEE-guided cardioversion. If you're unstable for whatever reason, of course, the job is to stabilize them and admit them for inpatient management. So let me end with some examples. 48-year-old man, atrial fibrillation with less than 48 hours. First onset, you've done your due diligence, normal thyroid function, chest X-ray is normal heart size, and the ECG shows AFib with a ventricular rate of 120 to 130 beats per minute. What do you do? So in this group, it belongs to a low-risk group. You could start antiarrhythmic drugs. I would recommend flecainide, not amiodarone. All right. If that fails after loading at 2 milligrams per kg, which is just one valve of 150 milligram, over 10 to 15 minutes. If that fails, do consider cardioversion. If they're stable, send them back and see a cardiologist for a workup. What about a 68-year-old female, known paroxysmal atrial fibrillation, already on anticoagulation, all right, had palpitations for 2 to 3 days, comes in with an ECG and with AF or ventricular response of 120 to 130 beats. She belongs to this low-risk group too, because she's already on anticoagulation. And if you check her data, she has remained on therapeutic anticoagulation. Do the same thing. She's already on drugs. Consider electrical cardioversion. If they respond well, send them for an early cardiology review. What about 72-year-old man with atrial fibrillation? All right, not on anticoagulation. First episode, chest VAS score of 3 with a stroke risk of 3.2% per year. Belongs to the intermediate risk, or belong to the high risk group. Now, you may just, I think it's appropriate to start anticoagulation, rate control, and then with response to rate control, send him home for an early cardiology review. However, if rhythm control is recommended, or you think it will benefit this patient, as mentioned in previous slides, admit him for a TE, and we would just do a TEE, and that guide our strategy for cardioversion. Now, what about same man with atrial fibrillation, EF 45%, non-OAC, mild renal impairment, primary congestion on X-ray? I think that belongs to the a little unstable group because there are signs of organ dysfunction or organ hypoperfusion. Admit them, stabilize them, and the cardiologist would normally work them up, and usually would do a TEE-guided cardioversion. So I think, in conclusion, ladies and gentlemen, there are a lot more we could do at the ED in patients with atrial fibrillation. We could definitely start stroke prevention, and evidence have shown that if you start them on medication to reduce stroke risk, there is a higher compliance and higher acceptance of long-term anticoagulation. Remember, there are some patients who are suitable candidates for aggressive rhythm control. Identify them, do the needful, and they'll be very grateful to you for restoring normal rhythm. Commence rate control agents with or without antiarrhythmics, and early follow-up, if possible, instead of an unscheduled hospitalization. With that, well, thank you for your attention.